So our next, I think it looks like we're right on time. Our next presenter will give us a perspective on tribal engagement in Indian health modernization. We are really pleased to welcome Dr. Stewart Ferguson from my home state of Alaska, and he will be here to discuss with us the role of leadership and tribal engagement in planning and managing health IT modernization processes. You all know Alaska went with the Cerner system, and they have actually developed and customized a whole system, integrated electronic health record that goes from the village clinic to the regional hospitals and into the tertiary medical center in Anchorage, and has made a significant impact on the delivery of care within the state of Alaska, as we all refer patients to the various healthcare facilities. So Dr. Ferguson is well respected for his leadership role as CIO for the Alaska Native Tribal Health Consortium. In his role, Dr. Ferguson has primary responsibility for health IT operations for the Alaska Native Medical Center, which is the largest Native medical center in the tribal health system. We're very proud of that. Dr. Ferguson previously served as the Chief Technology Officer for the Alaska Native Tribal Health Consortium, with primary responsibility for the expansion of single patient record EHR throughout the Alaska Tribal Health System. He also sits on the Information Systems Advisory Committee as the representative for the Tribal Self-Governance Advisory Committee to the IHS director. So again, just a reminder that we ask, if you have a question or comment during the presentation, please reserve it for the Q&A portion of the session or drop it into the chat box. And if you do have to leave, please send your comments via email. So welcome, Dr. Ferguson. It's great to have you here. Thank you.
Thank you very much, Carolyn. Hey, just checking, can you hear me okay?
Yes.
Great. Okay. So I'm going to share my screen. I don't have the rights. Oh, there we go. Fantastic. Can you just confirm that you can see the first slide there?
Yes, we can see it. Thank you.
Great. Thank you. Well, thank you very much for inviting me to join this conversation today. I'm going to be talking about tribal engagement in IHS's modernization project. A lot of what I'm going to present is kind of a summary of things we've learned over the last decade, more than a decade, in building out EHRs in the Alaska Tribal Health System. And in some cases, it's lessons learned and things that I wish I'd known 10 years ago. And I think we're still kind of relearning some of these lessons, especially as IHS is moving pretty fast and pretty aggressively. And as tribes, I think we need to be more engaged and more involved. Special thanks to Jonathan Revis. He's the director of the EHR at the Alaska Native Tribal Health Consortium, and Kristen Cady, director of clinical informatics. They are stalwarts in the expansion and management and care of our system, and a lot of the ideas I'm presenting are courtesy of their expertise. So we've kind of talked about this in a lot of different venues, but I think two key things to know. One is this is a full replacement of RPMS, and actually that's really key. That was not the assumption at the beginning of this project. In fact, the three other options that they discussed had some flavor of RPMS blended in. But the other part is this phrase, through the implementation of a centralized, modern core HIT system. So it's not saying we're going to just give you an EHR, it's really an IT system that we're actually talking about. The other aspect is this word modern. And it's kind of funny, we think that modern means if we buy the latest version from a vendor, it's modern. And I'd say it's not quite true. My argument would be that the federal government defines modern. And they didn't do this prior to 2011. But beginning around 2011, which happened to be when we went live with our Cerner system, the federal government decided to start to place regulations on what an EHR should do and how you should use it. And they started off with this concept of being a meaningful user. And eventually that became meaningful use stage 1. And the idea is that they wanted you to use an EHR meaningfully. It's a strange phrase, but it's one that's stuck over time. And it's kind of funny when I look back in 2011, and the concept of meaningful use had a condition that we must be able to print a visit summary and give it to the patient. So baby steps. Then they came out with stage 2 and stage 3, kind of increasing the demands on providers and organizations to really use an electronic health record and to engage patients. Beginning around 2018 and on from then, they started to talk about how do you interact with an electronic health record beyond the screen that the providers see. So you started to have, you had to have kind of a way to have applications talk to the EHR and embed applications in the EHR and share data with patients. And of course, now we've moved into promoting interoperability in 21st Century Cures Act with regulations that you will face fines if you block patients from getting to their data. You would be a data blocker. You have to have portals and support apps. And we're moving into this huge world of interoperability, moving from cost-based to value-based care. And that means that as organizations, we have to start to think about how we manage the cost, decrease cost, improve access, improve quality of care, and doing it within the context of an EHR technology. So there are incentive payments when you do this, and there are penalties if you don't. And so as we move forward, this is something that's going to become very important, I think, in the selection of the EHR. Now I'm showing you this just to give you a sense of what that really translates into. For us, it translated into growth in 2 dimensions. The one going up the vertical axis is the number of organizations and sites that we expanded on our shared domain. Now, this has really taken us 10 years. And the Indian Health Service believes that their project will take about 10 years, but theirs will be much more complicated and sophisticated than this. But it is hard to grow an EHR and add sites and hospitals and organizations and clinics and make that work, while at the same time, you're also growing in this other dimension. And that other dimension is adding solutions, upgrading solutions, getting rid of deprecated solutions, swapping them for other solutions, all because you have to meet these regulatory requirements. And the pace of this is unrelenting. It's amazing. We keep hoping it will slow, but it does not seem to. In fact, we used to do a major EHR upgrade every 3 years. We now realize we're going to be doing a major EHR upgrade roughly every 12 to 15 months. So what that means for organizations, once you move from RPMS to a commercial EHR, this is going to be a living, breathing system. And as you remove one solution to swap it with a more modern one or buy a new solution for regulatory requirements, whatever you're doing, you have to be involved in the testing, the deployment, the training, the support, the integration with other systems in your environment. So this is a complicated world. And I think we should all kind of go into it with eyes wide open, but it's a huge undertaking. Just if you've not really been involved in kind of stepping away from your RPMS system and going and buying a commercial EHR. And one of the things to realize is it's got a lot of pieces to it. It's not just an EHR. It has clinical pieces that are core to how you function, physician documentation, for example. It has departmental specific solutions. It has ambulatory specific solutions. It has revenue cycle solutions. It has connectivity and interface issues to other systems. And so the point is that when we bought our EHR, we bought it, I think, with roughly 40 solutions from Cerner. Now we're well past that number. And that number keeps growing. And each one of those solutions has its own life cycle management and support and training requirements. So the other thing to think about when we're talking IT modernization is that IHS is very specific, and I like what they've done. They've not called it EHR modernization, they've called it IT modernization. And that is because the electronic health record is not a standalone system, and actually it's not even a system that you're probably going to have in your organization. With RPMS, you had a server, you patched it, you managed it, you pulled data. A modern EHR is much more sophisticated, much more complex. It will use cloud computing for some of the solutions. And as a result, your whole relationship with this technology is going to change. And the relationship between that technology and the rest of your organization, not just the staffing, but your systems and your devices and technology is also going to change. And let me give you an example and walk through this a little bit. So I would call this the IT, or the health information technology ecosystem. So at the core, we talk about the electronic health record. We use Cerner. There are a number of tribal organizations that are on Athena, Allscripts, NextGen, HealthFusion. We're not kind of, we don't have a simple solution throughout tribal health. And then we also have our PMS. But in that electronic health record, you think about that's where you document patient care, birth to death, all aspects of the patient's healthcare. You also probably have an integrated revenue cycle solution that works with that. So you can do coding, billing, collections. You probably have departmental specific solutions for your emergency department, your surgery, and so forth. So it's a pretty sophisticated system. But then you have to think about the users interface with that, and users have specific needs. They need to have training, they need support, they have to understand the system. And it's not just providers, physicians and nurses, but your pharmacists are going to be using this system, your lab techs, your radiology techs, your radiologists, your external radiologists. So you have to think about how all those staff are going to interact with the system. And if you're like us, you're going to have locums. You're going to have folks that come or provide specialty care and have to access the system once they leave. So you really have to start thinking about supporting the staff no matter where they're at so they can access with your system. Then you have the devices, and most places that are using RPMS, you've got it figured out. You've got computers, possibly laptops, maybe smartphones, printers, scanners. But when you change electronic health records, sometimes those devices have to change. No longer will certain scanners perhaps work with the electronic health record. And so you have to be thinking through your device strategy when you change electronic health records. And then there's technologies. So we have gone and shifted towards using a lot of the Nuance products. They're called Dragon Medical One, Dragon Dictation. These are very powerful technologies that simplify the work for providers so they can dictate rather than type. They're coming out with virtual scribe solutions now where they can just listen to a conversation that a physician has with a patient, and it will document the patient's answers to the questions and create a structured document based on that interview. These are very powerful solutions, but they all require cloud computing technology. You need good network connectivity in your environment, Wi-Fi, connections to the wide area network. If you're connecting through telehealth, you need access to that. And we find that many organizations have to improve their connectivity as they start to go to a remote hosted electronic health record. You need to think about redundant connectivity, and you have to plan your downtime procedures for when you lose that connectivity or you lose devices. All kinds of services. Nobody will walk into your organization and hand you an EHR. It's a design build process. And then once you design and build it to your needs, because these things do have to be configured, you have to be able to test it. And it's not just a one-time testing. Every time you get a new solution or every time you do an upgrade, you have to go back to your testing plans and retest the system to make sure it's not going to be broken when you go live. And of course, ongoing training and support. At the patient bedside, you may have devices that have to be hooked up into the system, point of care devices, fetal monitors, ventilators, you name it, vital signs monitors. Those are devices that you probably want to find a way to integrate them into the EHR. Then you have all the systems in your environment that probably are not really part of the EHR. They may be, but if they're not, they need to be integrated and they need to be able to talk to the electronic health record. We find that the interface work required to maintain the EHR is one of the ones that we struggle the most with keeping up with. It's hard to find interface engineers, and when we find them, we have a ton of work for them. But you have to be able to talk to your lab system. You may have different pharmacy systems. You may have inpatient and retail pharmacy systems. If you have robots in surgery, dispensing units, dispensing meds or supplies, your PACS system for imaging. If you have a nutrition service and you want dietary orders to flow to your cafeteria, you need to do that interface. So the list is fairly endless in terms of what else you have to talk to in this world. Then you have the processes that really make your organization run. And I'll start with revenue cycle. So you need to be able to turn the documentation into a revenue stream. And this might be the biggest single change that organizations will see when they move away from RPMS to a commercial EHR. The revenue cycle tools that are available in modern EHRs these days are fairly sophisticated. And we find that many times organizations that haven't worked in that world find it challenging. Many more options, much more capability, but you really need to work on revenue cycle processes, education, training, because this is one place that it can really help you. You can probably increase the revenue capture for your organization if you focus on the revenue cycle. Supply chain, how do you order things and get them in? How do you integrate that into EHR? When the EHR pulls from a supply cabinet, can it tell your requisition center to go place orders? And then all the other integrations within your organization, legal compliance, you will be modifying your notice of privacy practices. You have to do it for certain solutions. And so you need a really good relationship with that. You need to be able to audit and do compliance checks to make sure the EHR is being used appropriately. Doug Barton just talked earlier today about the need for privacy and security. Well, there'll be auditing tools that you'll have to figure out how you're going to use them and really manage your system. Data, I will tell you, every organization on RPMS will struggle when they move to a commercial EHR, because over the years, most organizations have become pretty facile in being able to pull data from their RPMS system. A commercial EHR, many of them have very, very complex, what we call schemas, how the data is designed and stored in the system. And that won't become obvious right away. And many of the reports, the canned reports in the EHR, will not meet your needs. And so this is going to be a challenge. And I'm hoping IHS is going to be building out an analytics strategy and reporting capability and can help all the organizations that move on to commercial EHR to avoid this drop in data. Then there's regulatory requirements. You're going to have quality measures. You want to meet meaningful use. If you're Joint Commission or other accrediting organizations, you'll have to think through how you can manage and navigate through these and do the reports you need to do and survive the audits that you'll have to survive with a new EHR technology. So then there's the whole management layer. How do you continue to optimize this system with feedback from your providers, users, patients, so you can make a better system? How do you make decisions, governance, in terms of where you're headed? What are you going to add to the system? What will you subtract? You're into a world now where there's a lot of capabilities out there, a lot of things to buy from. And as you buy them and install them, or IHS buys and installs them, how do you do change management? How do you make sure staff are ready for it, they're trained for it, they can support it? How do you plan a roadmap of where you want to go in the next year to 5 years? So there's a very complex management piece that we're going to be embarking on. Patient engagement is kind of the name of the game these days. Any modern EHR will have a patient portal, but more importantly, there are other ways that patients can engage with your electronic health record. They could, you can buy solutions to do online scheduling for patients on demand. You can have them upload documents, you can do discharge, you can do notifications, texts, emails, and then they can buy apps that integrate to your EHR, and you have to think through how do you manage that world. And then you have this whole interoperability piece. How do you communicate to other places where your patients will move or get care that aren't on your electronic health record? If you're a tribal organization and you send patients to, say, a hospital in Billings or a hospital in Seattle or a hospital in Phoenix, how do you communicate with them? How do you do it in a push method with direct secure messaging? How do you do it in a pull method such as Commonwealth? How do you report to the state? How do you do reportable lab syndromic surveillance? Every state will be a little bit different. So this is a complex ecosystem that we're getting into. And this is why it's called IT modernization, not EHR modernization. So AC and Carolyn were talking a few minutes ago about the cost of modernization. I'll show you, I think, how IHS comes up with that number. They looked at the Veterans Administration that we'll hear from later. And I think the estimate is they'll have a 10-year spend of between $16 and $20 billion for almost 10 million patients. And if you do the math, it turns out to be about $1,500 to $2,000 per patient. So IHS with 2.6 million active patients has a 10-year price tag, and we say $3 billion, but it could be $5 billion. I mean, many of the sites are more rural perhaps than the VA has faced, and I think there are more sites, more challenges. So I personally think that the price tag will certainly creep towards the $5 billion and not the $3 billion, which means that the 10-year spend is about $2,000 per patient. And that means that if you have 1,000 active patients in your organization, your 10-year spend will be about $2 million. If you have 10,000 patients, it means your spend will be $2 million per year for 10 years. Now, we don't know how this is going to work with Indian Health Service, but they are quoting these numbers, and these numbers are based on the entire active population of American Indian Alaska Natives. But many of us have already moved to a commercial EHR at about this cost. So they're kind of quoting our costs to already have moved as part of their bulk aggregate. And yet we don't have a plan within Indian Health Service to reimburse those that have already paid for those costs, despite the fact our costs are being included in their overall price tag. So I think this is one of the issues that tribal leaders are facing, is how do we cover the cost that was spent when they're being quoted as part of the project? The other thing to be aware of is the Indian Health Service did a data call a few months ago, and they asked organizations that have moved to a commercial EHR to give them an estimate of their costs for the last 10 years. And we did that. ANTHD did it, South Central Foundation did it, a number of tribal organizations in Alaska provided that information. And I would say that our estimate for a 10-year spend is in line with this $2,000 per patient. It might be actually a little bit higher than this. But I would say these numbers are not out of whack. The most important thing, though, is when we did our analysis, we found that about 50% of our total cost over 10 years was staff time. It was not licenses from Cerner, connectivity devices, it was staff time. And everybody needs to be aware the staffing engagement at every organization is going to be huge to move to a commercial EHR. So this is slightly older data because I don't think we have an update yet from Indian Health Service, but they did a data call in 2015, 2017. And there are a couple takeaways from this. One is that the percentage of RPMS sites diminished, and the percentage of COT sites, commercial off-the-shelf EHRs, increased by over 50% in 2 years. And this shows data on the right in terms of the leading EHRs for hospitals and ambulatory sites. And Epic definitely paves the way and leads in the ambulatory space. Epic and Cerner are kind of duking it out for 1 and 2 in the hospital space. And that's probably still true even in 2021. This is another way of looking at it is if you look at the EHR systems in federal, urban, and tribal sites, this is in 2017. If you look at the RPMS sites, the federal space absolutely dominates with RPMS. 94% of the sites in 2017 relied on RPMS. Whereas if you shift to the urban sites, it's only at 70%, and if you shift to the tribal sites, it's 52%. So what that means is that tribal sites have been making headway and moving towards commercial EHRs for over a decade. There's a heavy presence of, say, NextGen in California. There's a heavy presence of Cerner, Athena, and some other EHRs in Alaska. It's not monolithic, it's pretty variable, but we've already been moving that way. So I think one of the questions that's reasonable to ask is, why should the sites that have already moved to a commercial EHR participate? What's in this process for them? If IHS is really just focusing on the sites that are on RPMS. And I'll say this, I think there's a huge reason why those that have moved to commercial EHR should participate. I'll give you a couple examples from our world. So we negotiate Cerner contracts at a fairly rapid pace. We have over 200 contracts over 10 years, so about 20 contracts a year that we negotiate with Cerner. If IHS moves to Cerner, then we would like to be able to perhaps leverage the pricing or any negotiations that Indian Health Service has with Cerner. I think if they move to NextGen or if they move to different technologies, people that are on that technology may be able to get preferential pricing for the future and perhaps move some of their contracts over to that price schedule. We may be able to get new solutions that we don't currently have, like purchased and referred care, that could be part of this negotiation. Reporting and data and analytics. We try to report IHS's specific measures, but that's a struggle out of a commercial EHR, but we might be able to leverage some of that capability if Indian Health Service develops it. We like the support and training that we can get from Indian Health Service. I think folks have enjoyed that for years with RPMS. It would be nice if they could support the commercial EHR I'm on, and I could rely on their tools and systems and staff to do support and training. The rest of this are other examples. If they start to license third-party solutions like a new lab system, a new pharmacy system, a dental system, that may be beneficial to us. If they build interfaces at the state, local, or federal level, we might be able to leverage some of those. As they start to connect to national health information exchanges, I think there's value for us to participate or be part of that. I wrote pan EHR solutions here. So when it comes to things like patient engagement, there are solutions that are not specific to one EHR. So you could get a solution that allows patients to, say, self-schedule, upload documents, and get reminders that would work above the EHR. So it could tie to a next-gen system in California, a Cerner system in Alaska, a Health Fusion system somewhere else. So there may be some technologies here that are really not specific to the EHR. So let me talk about EHR models, and this is a very important thing to understand. I will say up front, I think anything that Indian Health Service is going to do is probably going to be remote hosted. I doubt you will have an EHR server sitting in your organization. You may have a field monitoring server. You may have a scanning or document imaging server. Those things are not uncommon, but the EHR itself, the database and the front end and the middle tier are probably all going to be sitting someplace else, and you're going to be connected to them. So this is the RPMS model, and I apologize for simplifying it, but this is the world that we've lived in, I think, is that we've really all had independent RPMS systems. We locally patch them, we configure them, we customize them, and they don't really share data between RPMS systems. You can do it with direct secure messaging, but they're really kind of bubbles to themselves. This environment is most configurable to local needs, and many, maybe most, are locally hosted in your server room with your IT staff. So they're independent systems. And if you've lived in that world, the world of a modern EHR is dramatically different. So I'm going to present three different models and tell you which one I think we're going to end up on. So there is a way to replicate that with a commercial off-the-shelf software, and I would call it the independent model. So again, you would have your own medical record, your own software for doing it. Is configurable. It would allow organization one to buy from one vendor and organization two to buy from a different vendor. This is probably the most complex model we could come up with. It's hardest to support and maintain. And I really think it's the least likely model for Indian Health Service to move to. What I think is the more likely model is what I would call a community model, where you may have multiple folks, but they're all sharing the same software. So they're on the same version of the software for the emergency department, the pharmacy, and so forth. It will be tweaked and tuned to local needs, but it's still one version. They're all on version 5 of the emergency department. They all have the same solution for the emergency department, but they each have their own medical record. So kind of on the back end, you have a different database for each organization. It's one of the lowest cost models because there's really just one package of software. It's probably the least flexible because you really have to all live on the same software choices and systems. Requires some effort to build and to govern this, but it is probably the most efficient model. And I think when IHS says they're going to a centralized EHR, I think this is probably their vision of where it would go. Cerner sells this kind of a model. They call it Community Works. Everybody gets the same package, the same number of options on the EHR, and then with a majority vote, you can add systems. You all upgrade at the same time since it's one software package and so forth. So it's a little bit easier to manage and maintain, and it's very cost effective for the most part. Then there's what we have in Alaska, and we call it a shared domain, where again, it's one software system, but it's also one medical record and allows the patient's information to be seen at any site they go to that's in this system. It's a beautiful way of sharing patient information. It's probably the most complex to build and govern, because you really all are in on this, and you have to kind of recognize changes that you make may impact others. But it works well for integrated delivery networks, and we use it for about 75% of healthcare in the Alaska Tribal Health System. And then, of course, you can mix and match. You can mix the independent and the community and the shared domain model. I don't think this is something that would make sense, and I'd be surprised if this gets offered by Indian Health Service. I think they're not going to do that. So let me talk about governance. Once you get into this world of commercial EHRs, the speed you can move depends on your buying ability, not on your development ability. In the past, we've been limited by how fast Indian Health Service could take VA code or develop their own code, modify it, and release it to tribes, and then the speed of which you can patch and upgrade. You're not doing that for the most part. Now, mostly you're going to be buying a solution that's generally available from your EHR vendor, and the limiting fact will be how fast can you put it into your system, configure it, train your users, interface, and use it. So the speed is different, and it requires a road mapping process to really understand what you're going to do. Once you tie in regulatory requirements, that will push a lot of your efforts into a very strict timeline. If you have to be on this version of code by 2021, and you have to develop metrics for the full year, then you've got to start doing things in 2020 to get ready for 2021. So you need a multi-year roadmap for purchasing, installation, configuration, training, and testing. And we do it right now with 21 organizations. I can imagine the Indian Health Service could be in this business and doing it for all the federal sites, and potentially working with tribes for their sites. So this is huge. So how do you manage in this world to make sure that you're buying what you need, that you have a roadmap that makes sense, you're taking care of local needs as well as system needs? And the answer to that is that you need, we call it a management model, but it's really a governance model. And don't get confused by all these boxes on this. It's kind of the concept is tribes need a voice in this system if it's going to be successful. We have built a fairly complicated governance model, but what we do is we allow for voices at all the different levels. So at the very bottom of this, we make sure that we have subject matter experts, folks that know how community health aides work, registration and scheduling, providers, lab, business office, behavioral health. Those are the folks that have to all work together to make decisions on what we have to do in the electronic health record. They meet every week to make decisions on what they're going to release to the system, the changes, what they're going to look at prior to releasing it to the system with change management. We have statewide committees, we have a steering committee, and then we have layers of approvals above it. The challenge for us is making sure that we hear from everybody. So how do you get input from the small sites at all levels? How do you make sure that everybody understands the issues, they understand the regulatory requirements, they understand the why of what you're doing, and that they feel empowered to make the right decisions as part of this process? And how do you develop a shared strategy moving forward? I think this is important. I think this is something that tribes need to be participating in, because done right, I think you can really get an EHR that works for your needs as well as the system needs. So this is just a scatter plot. If this really is going to be your electronic health record, it needs to meet your needs. I've thrown things up here. These are some things that we've discovered over the time that vary between organizations. Some of you may have these issues, some of them you may not. Something as simple as nutrition services. How do you make sure dietary orders move to your nutrition service? Ours are contracted out, and different contractors use different systems. So it would be nice early on in the stage, if you want an interface, to specify that they have to be able to interface to this particular system. So it comes down to requirements, knowing what you need, knowing how you operate, and making sure the electronic health record is going to meet your needs in the long term. So let's talk about tribal engagement in this IHS project. I met with our team and we were preparing a slide presentation to go to one of our tribal partners that had recently joined the EHR. And I was asking my team, what are the 4 or 5 key messages that we really want to make sure people hear from our staff? And, they started off with, changing an EHR is hard. It really doesn't matter if you're going to Cerner, Athena, NextGen. It's a hard process. It takes a lot of time, it takes a lot of effort, and it's not going to work first time. It's going to take care and feeding. The second is, and this is very important, we don't go into an organization and build it for the organization. We build it with the organization. We don't know necessarily the workflows or the uniquenesses or the needs of each organization. The experts on that are in the organization. So we work with them. We go through design criteria. We have design sheets that we work on, and we build it for them. The third is, we do want to make this work better. We're committed, and we want organizations to understand it, even when they may feel like we're not fixing their problem ahead of somebody else's. It's a challenging issue to make sure everybody's issues are being dealt with in a timely manner, but we are committed. The fourth is that we actually believe that our mission is to give an organization the best EHR, not just a shared EHR. So if it doesn't do what it does, what it needs to do, if it's not optimized, if it's complicated, it's our job to try to work with organizations and make it a better EHR. I wouldn't say that we hit this every time, but that's our commitment. We believe that that's what we need to be doing. And the fifth is that every organization has a seat at the table equal to every other organization. It doesn't matter if you're a huge hospital-based organization or a small ambulatory clinic. If you're on the system, you get a vote. So that's our approach. And we always finish with, we need you, for this to work, we all need to communicate and we all need to participate. This is what I wish Indian Health Service was saying to tribes today. These are the statements we need to hear. They're building it with us. They're committed to making it work. They want to give us the best EHR, and we all have a seat at the table. I believe Indian Health Service's intentions are to be there for tribes, but I think the challenge is the tribal input at this point is not, I think, where it needs to be. I think this is a slide from the Indian Health Service. They do have an intention of creating a number of groups, and the little red lines around some of these indicate where we will be able to participate. We need to be able to participate in developing a governance model, road mapping, requirements development, reviewing the solutions. We need to do all of this. I feel that the input to this point has been thin, but I think these are the places that we need to be participating, or we need to be working with Indian Health Service to find other ways to provide input. So I'll finish with a summary slide. Why would you participate in this process? Well, a couple things. One, this is not RPMS. It's not going to be anything like RPMS. And unfortunately, IHS is not the expert. They haven't done a COTS EHR. They're not the expert. They're relying on some consultants to help with this, but it's not like the old world where RPMS, they gave us patches, they knew it inside out, and they could provide lots of support and training. This is new to everybody. Second is, this is going to be a massive change. Like I said, 50% of our costs are staffing. It will affect every part of patient care in your organization. It's huge. Third is, you have local requirements and you have your own needs. We need to find a way that those needs are available to the Indian Health Service, so the system, as they go through the RFP process and eventually build it, will meet those needs. you need to understand when it does come to your organization, what it will do in terms of resources, time, and change, but also the benefits. I think a lot of times we look at this as a project that takes effort rather than a project that reaps benefits. And there are significant benefits to going to a commercial EHR. Everything from patient engagement, certain efficiencies, improved revenue and collections. And those are things to be thinking about. It will be expensive in terms of the time it will take from your team. I believe that tribes and Indian Health Service must develop a shared governance model, and I think we need to do that early. I don't think it's something that you do 5 years into this modernization effort. And then probably the most important thing, as you participate in this process, you will learn. You will learn what the EHR can do, what you need to be thinking about for your organization. It will be a learning process, not only for Indian Health Service, but for tribes. And I would just emphasize again, I think the COT sites, those of you who have gone down this route, will also benefit. I would not avoid this because you've already moved to a commercial EHR. I think there are opportunities to benefit from it as well. So with that, Carolyn and AC, I'll finish. This is our contact information. If you need to reach me or Jonathan or Kristen, I've put our titles and emails up here, and we are always willing to participate and share what we have learned to this point with tribes. So thank you.
Thank you, Dr. Ferguson. And I just wanted to highlight, we have time for one question. So if someone does have a question, please raise your hand or type in the chat box and we will call on you. Just want to note our time is short. So if you do have questions and we don't get to them, we encourage everyone to put them in the chat box. And after the summit, we will, with your information after summit, NIHB will get to Dr. Ferguson if you don't email him directly. So they asked if you could put the information back on the screen. If we have any questions, feel free to raise your hand and we will.
Sorry about that. I put the contact information back up there again. So it's just sferguson@anthc.org.
It doesn't look like we have any questions right now. Like I said, you can send your questions to Dr. Ferguson or you could drop them in the chat and we will get those to him. In that case, Carolyn, I will recognize you to introduce our next speaker.
Okay, thank you. And thank you again, Dr. Ferguson. I think it's really invaluable to hear your analysis, especially on the cost pricing, and then share your perspective on reasons why it's important to stay engaged in the Health IT modernization effort put forward by Indian Health Services. It's also, I have to say, very comforting to know that we have knowledgeable expertise within our tribal health community as we move forward on this journey. And I know, AC, we've talked about calling on other tribal tribes to allow them to share their experiences as well with migration to a COTS system in future sessions. So we will take advantage of all the expertise we have in Indian country. So we do have a